I'm Oonagh, and I'm going to talk to you about the Viscort project. It's a large €6 million project which we're running here at NUI Galway. And the aim is to restore sight with corneal transplants. And also to use what we're learning about the biology of transplants and apply that to other organ transplant fields like kidneys or heart valves or hearts themselves. The project is led by Professor Matthew Griffin, who works here at the university. He's also the Professor of Transplant Biology at Galway University Hospitals. So just to set the scene, there's a few kind of numbers on blindness and vision impairment, and that's really what we're hoping to improve and treat. So there's 40 million people in the world who are blind and 300 million people who are affected with visual impairment. And corneal opacities, which is what we deal with, what we work on, are the fourth leading cause of blindness globally and affecting 10 million people. So I don't think I need to explain to you how debilitating blindness could be, but there's all sorts of complications which I think a lot of us who have perfect vision or just are slightly visually impaired like myself wouldn't even think about, like sleep disorders. I thought was quite interesting. When you can't see light, when you don't register light, it interrupts the circadian rhythm, so you can't get your sleeping patterns right. For people whose blindness or visual impairment is caused by disease or injury to the cornea, there is a little bit of hope in the form of cornea transplantation. More than 1 million procedures, or more than 1 million people have had their sight fully restored since the 1960s using cornea transplants. It's very successful surgery, so you can have it as an outpatient. It takes 1 to 2 hours. You can have it just with local anesthesia, so your eyes are open the whole time. I hope I never have to have one. And you're home in a couple of hours. But you will need to be treated with immunosuppressive therapy afterwards. It might take 12 months for the vision to recover fully. It'll be blurred, but we have had patients in the past who are back at work within a week, which is amazing. The science bit of the project really is about the immune system, and this is again the hostile body that Abe and Eilish have mentioned. The main problem for transplants is an adverse immune response. So rejection of a transplant occurs when the body's immune system detects the transplant as a foreign body and tries to kill it, tries to destroy it. So that's the big problem, that after the surgery, once a donor is found, donor tissue, and once you've had the surgery, your main problem thereafter is immune response, trying to control your own immune system to keep the transplant in place and functioning. Rejection of the donor cornea is the most serious and complicating factor after a transplant. It occurs in 5 to 30% of patients, and following any transplant, cornea, heart, whatever, patients will need to take some sort of immunosuppressive therapy, probably for the rest of their lives. And that's not an easy therapy to take. An immunosuppressive drug will suppress the immune system, so we'd be more likely to get any sort of disease. The common cold could become very serious. But also the drugs themselves are very, very toxic, very heavy on the liver, and can cause permanent liver damage. So if we can recognize the early warning signs of a corneal transplant rejection, that's the first step in preventing a transplant failure, and that's what we're trying to do in this project. So we've put together a team across Europe, a crack team of transplant centres. So we've worked with 5 different hospitals across Europe, including the Royal Victoria Eye and Ear in Dublin, where a lot of the transplants in Ireland take place. We have 4 academic partners who look after all the science and immune work. And we have 3 SME company partners. So we're all working together to try and understand the immune system following transplant a little bit better. So that's all of us there at a recent meeting in Denmark. I'm going to talk to you a little bit about corneal disease. So I have some horrible pictures in this slide. The two top pictures on the right are the perfect cornea. So the cornea is the tissue at the front of the eye, and it has to remain transparent in order for us to see. Light has to pass through to get to the retina where the rods and the cones are, and they send the signals to the brain and we can see. But if there's any damage or disease to the cornea, then it will lose this transparency and our vision will be impaired. We can often lose sight completely. So there's lots of different causes. All down here on the left-hand side, there's different presentations of corneal disease and injury, from keratoconus, which is a kind of a degenerative disorder of the eye. It's quite common. As we age, it just loses its shape and clouds over. It could be just misuse of contact lenses, or an ingrown eyelash can permanently damage the eye. The bottom picture on the right is a hepatic ulcer. So that's caused by the same kind of herpes, which causes the cold sore virus. That's quite a common reason for transplant. So if this damage is permanent, then we can lose our vision permanently, and the only option is a corneal transplant at that stage. So transplants have, this is a cornea that's just been transplanted. The sutures are in place to keep the transplant in the position. They'll be in for about 2 months, and then they're generally removed if the transplant goes well. So they've been performed for over 100 years, and they're very, very successful surgeries, really. They're the more frequent than all other organ transplants combined. So you get the donor tissue from eye banks. If you're picked for an eye transplant, you can generally get a donor tissue within 1 or 2 days, because donors can be quite old for cornea transplants. That's quite dissimilar to a lot of other types of organ transplant. The surgical technique continues to evolve, but the immunotherapy that's needed afterwards has kind of stood still for the last few decades. There aren't that many options, and that's what we're trying to improve. You can categorize a patient who's going to have a transplant as being of low or high risk, depending on the disease or the injury that they have, their past medical history, whether their immune system, if they have any sort of autoimmune disease, then they're at very high risk of transplant failure and rejection. But if you have a low-risk patient, then the rate of success of transplant is very, very high, and generally you would use just a steroid in an eye drop for 1 or 2 years, and that's all the drugs you need for a successful transplant. So because these transplants are performed so frequently, 100,000 per year, we see a lot of different adverse immune responses. So we're going to use this to collect a lot of data, and it's an opportunity to study excuse me, immune responses that are associated with rejection, and develop new tests for early diagnosis of rejection and to prevent rejection. And when we have all this data collected and combined and analyzed, we're hoping to use the cornea as a proxy for other organ transplantation. Another ugly picture for you. It's of a cornea transplant rejection. So you can see the cornea has become a little bit opaque. It's all inflamed. The blood vessels are growing into it. That's not supposed to happen. So this patient is losing their vision. Cornea transplants, within 5 years, 20 to 30% of them will fail. Within 10 years, 40 to 60% will fail, and that's what the graph there is showing you. So you don't generally just have one cornea transplant. You'll probably need another one in a few years. And for every successive one that you have, you become a more high-risk patient, so you're more at a chance of rejection. It's the most important influence on long-term survival, and it's treated with increased immunosuppressive, so you have to take an increased amount of these toxic drugs. So we're looking for more effective and less toxic strategies. So the first thing that we're doing is a very nice clinical study. So we're registering 700 patients at the 5 different clinical centres, the 5 different hospitals across Europe. So this is consultant surgeon Conor Murphy in the Royal Victoria Eye and Ear in Dublin, and he's just examining the first patient that was registered in Ireland, and he subsequently went on to have cornea transplant. We've already got 358 patients registered, and at each of the sites, so in Dublin, at Nantes in France, Aarhus in Denmark, Charité in Berlin, which I think is the biggest hospital there, and the University of Bristol, which is the home of the UK Eye Bank. We have a clinical nurse working at each of those hospitals who talk to all the patients, explain what we're doing, consent them, talk to them before the procedures. If they agree to take part in the study, take some blood samples, tear samples, take them through the transplant, and then follow up with them for a few years afterwards to see the outcomes, how they respond to the treatment. Do they have any adverse immune reaction? Do they have a rejection? And with all the samples, we do a whole lot of science. And I only have one kind of scientific slide for you. The pictures show all the work we're going to do. But in short and in essence, what we do is collect all of these samples from the patients and analyze them in the lab. And we're looking at the body's molecules like DNA, RNA, proteins, and immune profile. And we're examining them to find our own, or every patient's unique fundamental biology. So we're all different. And we all have different DNA, and we all have different RNA. And depending on our medical history and our immune response to different things we have encountered in our lives, we'll react differently following transplant. So we have all of these samples, and we are going to find out all these signatures for every patient. We can compare them to the clinical outcomes, so we'll be able to identify markers that will signify and help to predict that a patient will reject a transplant. So we're hoping with all of this information to answer the following questions. Will the transplant be successful? What immune profiles would indicate a rejection? And are there biomarkers that we could use to predict and diagnose an adverse immune response or a clinical outcome? So is there some kind of signature in any of our body's molecules which would enable us to go, this patient will reject? So the benefits, if it all works out, and if we can find these markers, is that we'll have new approaches to preventing adverse immune response after a transplant. So we're hoping to develop new diagnostic and prognostic tests which will predict the likelihood of success or failure of the transplant just from taking a simple blood test and analyzing the sample. If we can predict the risk, if we can say, oh, there's a patient who we see this molecule here, they're going to reject the transplant, we can tailor an immunosuppressive therapy for that patient, and that's very individual and specialized care. So it's a movement towards personalized medicine, which is a big thing in medicine right now, where moving from this kind of one-size-fits-all approach, one treatment for everyone, to a more individual style of care. And the second benefit that we're working on, which I haven't mentioned so far, but is very, very exciting for us, is that we will begin a clinical trial of a new therapy, an immunomodulatory stem cell therapy, in the next couple of years. So we're going to use stem cells, which I'm sure all of you have heard about, and they have all these sorts of wonderful properties. But one that perhaps not many people know about is that they have the capacity to affect the immune system. They can change immune response in a very, very short time. So we want to know if stem cell treatment could prevent an adverse immune response in transplant patients, and we believe the answer is yes. We've done a lot of preclinical work here in the university, and we've shown that with one infusion or one treatment of stem cells in an animal model, we can prevent corneal transplant rejection. So very, very excited about that, but the dosage is incredibly important, so we have a lot of work to do to make sure that it's safe before it enters a clinical trial. So some of you might have heard about a clinical trial that went wrong in January, I think it was, in France, where a patient died, a healthy volunteer patient, who was being treated with a novel, I think it was a drug for depression. And as the trial progressed and they upped the dosage, patients had disastrous responses. So There's a lot of work to do. It's very exciting, but we don't do it lightly. So in the next couple of years, we hope to be ready for clinical trial of this new stem cell therapy for corneal transplant patients. So it will take place in Charité Hospital in Berlin, but it will be led by NUI Galway with the partners Orbsen Therapeutics, which is a spin-out company of the university here, which was, it was originally set up by NUI Galway researchers, and they do really, really exciting work on stem cells. They're based here on campus. So we're going to recruit 9 patients who are at a very high risk of transplant rejection, treat them with a single IV infusion of stem cells, just a drip, hook them up to a drip, and then afterwards just the eye drops, the steroid eye drops. Hopefully it'll be safe, it won't produce terrible side effects, and it'll be effective in stopping the rejection. So it's quite amazing, to me anyway, it blows my mind that you can have a single infusion of stem cells shortly after the transplant, and that will have a long-term effect on the graft survival or the transplant survival. Because when you infuse cells into the body, the residency time is very, very short. They stay in the body only for 1 or 2 days. But that seems to be long enough to have a permanent effect on the immune system. Final slide for you is a little bit busy, but it kind of just summarizes the work that we're going to do. So the top part is the clinical study where we register these 700 corneal transplant patients, take their samples, analyze all the samples, monitor their outcomes, compare the two in a huge supercomputer, and come up with biomarkers or molecular signatures in their blood or another bodily fluid that will indicate rejection. And that can be developed as a new diagnostic tool by a company. It'd be very, very useful for transplant surgeons. And the second part is the stem cell trial. It's really very exciting for us. Not a lot of the research that we do actually gets to clinical trial. So very, very exciting, the use of this stem cell to modify the immune response for corneal transplants. I hope now I made that clear for you. The project website is viscort.eu, and it was funded by the European Commission's 7th Framework Programme.